health needs of women and girls in resource-poor settings. Sarah's worked in a variety of humanitarian settings, including Burma, Haiti, Indonesia, Jordan, Mongolia, Papua New Guinea, the Philippines, Sudan, Thailand, Tibet, Timor-Leste, and amongst many others. She holds a master's degree in human rights with concentration in health from Columbia University and a bachelor's degree in sociology with concentrations in gender and labor studies from New College. And Sarah is originally from Germany. Our other speaker is Dr. Gretchen Berggren. She will be speaking secondly, and she's from the University of Colorado. She's a graduate of the University of Nebraska College of Medicine and the Harvard School of Public Health, where she served on faculty from 1968 through 1983, teaching international health and population sciences, as well as conducting field programs in Haiti. She's also taught at the University of Colorado School of Public Health. Dr. Berggren has lived and worked in Congo, Haiti, and Tunisia, amongst many other countries, and has worked with Save the Children and World Relief in more than 26 countries. Her work alongside her husband in reducing mortality from neonatal tetanus, rehabilitating malnourished children, and implementing a pioneering census-based program utilizing community health workers that has laid the foundation for many similar programs around the world. So let's welcome our two speakers.
Thank you very much. I feel like you've just learned a lot about me. Let's see, I wanted to thank the organizers today for bringing me out here. I'm based in California. I really appreciate all the support, and I'm happy to be here. I'm going to talk a little bit this afternoon about the differences between the policies in place around reproductive health and emergencies and the actual implementation in the field, and what that gap is. Why isn't, or what are the challenges in translating the policies into practice? One thing I hear a lot, and less so thankfully these days, but especially when I first started out, was why? Why should we address reproductive health and emergencies? Food, water, shelter, those are the priorities. And I'm going to lay those out for you first before we go into the details. I can actually look over here. There are a number of reasons why we need to address reproductive health and emergencies. The magnitude of the number of people who are affected by crises. It's a life-saving intervention. It's a human right that everyone has access, should have access to, and it's also now a global standard. Right now there are about 45 million, actually this data is from the end of 2012, so approximately 45 million people are displaced from conflict and natural disaster, and about 75% are women, youth, and children. And usually I don't like to lump women and children together in the same sentence, but I think it's important to realize that war and conflict does not just affect the people, the men with guns who may be fighting the war, that the majority are the civilian population. So my question to the group is, what do you think the average duration of a refugee situation is? So if you are in Syria now, and you leave and go to Jordan, how long do you think you would anticipate being in Jordan before you could go back home? As a refugee, not an internally displaced person crossing a border.
3 months.
3 months, thank you. Anybody else? Going.
10 years.
10 years, 15 years.
30 years.
30 years, all right, we have a vast range. It is 17 years, so 15.
Wow.
That's a very long time. These emergencies, they aren't short. People need reproductive health services. 17 years, that's almost a generation. Reproductive health, it's a life-saving intervention. Reproductive health problems are the leading cause of ill health and death among women of reproductive age, which is about 15 to 49 in the developing world. The majority of maternal deaths are preventable if people have the right care. Even though AIDS-related deaths are decreasing, and there's been a lot of movement in terms of HIV, we still have 1.6 million people who died of AIDS-related illnesses in 2012. Men absolutely have reproductive health needs. They have a right to reproductive health. They want reproductive health services. It affects them as well. And there's a high psychosocial toll. It's not just the clinical or the physical aspects, especially around sexual violence. So when there's an emergency, the risks increase. For example, the risk of sexual violence may increase, and then your access to care decreases. STI transmission, sexually transmitted infections may increase, although the data on HIV are unclear. So in some settings, HIV may actually be a protective factor. For example, if you're a low prevalence group going into a more high prevalence country, being isolated in a camp, for example, might serve as a protective factor. You don't have contraceptives, or you may not have contraceptives. To give an example, when I was working in Jordan, I met a lot of Iraqi refugees there, and women would say, actually one woman, and a lot of other people confirmed this, but one woman gave this example that her brother would go back to Iraq to smuggle goods over to Jordan. And the number one thing that she wanted were her contraceptive pills. She's like, I can't get pregnant. I want my pills. Then that was the number one thing that she asked for. Emergency obstetric care, as you can imagine, increases the risk of death and disability. We know that reproductive health is a human right, as articulated in these different international conventions and agreements. And to give a little bit of history of reproductive health on the humanitarian agenda, in the 70s and 80s, when international humanitarian work really started to take off with the rise of the NGOs and people and agencies starting to work in like Biafra or Somalia, Ethiopia in the 80s, reproductive health was not on people's minds. It was not, I mean, humanitarian response was pretty cowboy back in the day. People coming in and saving the world. And reproductive health just wasn't on the agenda for lots of different reasons. And it was in the mid-90s that things really started to change. So we had the war in the genocide in Rwanda, and then we had the Balkan War. And I think what happened there is it was the first time that the world really saw the way that war played out on women's bodies. So you saw the rape camps. You had the images of the rape camps from former Yugoslavia. Rape camps have happened throughout history, Berlin, World War II, but we don't have those images. They weren't so visceral, we didn't see them. In Rwanda, the sexual violence that happened, we saw the images of women with their breasts cut off, for example. This really brought it, I think, this really brought the issue to the forefront of the public's mind. Also in '94, there was the first study from the Women's Refugee Commission. They commissioned this study. I think they went to 8 or 9 countries around the world to find out really what's happening in camps, what's happening with women. They found that, yes, reproductive health services are generally not provided, and more than that, it's what women wanted. Women said, we don't want to become pregnant now. We are tired of not being able to get the right maternal health care. We are at risk for sexual violence. It's something that they verbalized that they really wanted and needed in their lives. Also in the mid-90s, there was the International Conference on Population and Development. The Program of Action is '94 in Cairo. And that was the first time that reproductive health for refugees and conflict and crisis-affected populations is specifically articulated as a right. Then we have 2 groups. The RHRC is a group of 7 American NGOs that's still in existence. And then the IWOG, which is sort of an odd acronym, but the Interagency Working Group on Reproductive Health and Emergencies. That's when that group started, and it was more of a loose clearinghouse of NGOs, UN agencies, academic institutions that came together and said, look, we have got to do something, we have to address this situation. We want to advance reproductive health. So one of the first things that they did was create a field manual. Even if you want to implement reproductive health services, what do you do? What are the priorities? So the Interagency Field Manual, the one on your left, yes, that's your left, was developed in 1999. The second one is an updated version from 2010. We're still field testing that. But what was really important about the 1999 version is that it specifically outlined the minimum package of services that should be put in place in an emergency, also called the MISP, which I'll talk more about in a moment. At the beginning of a crisis, you can't do everything. It's impossible to provide comprehensive care. And this group, the IWOG group, came together and identified what those minimum services were, which was very critical in advancing reproductive health. In terms of policy improvements, reproductive health has come a long way since I first started in this field. It's integrated into key policies and documents. The sphere standards, which I'm sure many of you are familiar with, outline the minimum standards across all sectors: health, Watson, protection. Actually, I don't think protection was originally included. The CERF, the UN Central Emergency Relief Fund, included reproductive health as a minimum life-saving criteria, again giving further legitimacy to the idea that it is life-saving and minimum standard. And then in 2009, the global guidance on a health response integrated it. So all this is to say, this was really to outline there have been major improvements. Reproductive health absolutely needs to be implemented. We've come a long way on the policy level, but it's still not translating into systematic implementation. Why is this? One of the main things that we see is that there's now increased awareness. So when I first started in 2003, I went to Darfur and nobody had heard of the MISP, this minimum standard in reproductive health. We met one person, we were in Darfur for a while, nobody had heard of it, nobody was doing it. In Haiti, after the Haiti earthquake in 2010, there was much more awareness. A lot of people that we interviewed had heard of the MISP, knew about reproductive health as a minimum standard. They weren't implementing it, but slowly we are getting there. So there is increased awareness, but there's a lack of trained staff. There's a lack of coordination, which I'll talk more about. It can be perceived as inappropriate. Sometimes we'll hear, oh, but you can't give condoms here. The population, it's too sensitive. If you make condoms available discreetly in latrines, for example, people will take them, they will use them. It's not easy to set up reproductive health services. In a lot of settings, there are major insecurity issues. You can't access the referral hospital for a woman who's having an obstetric emergency, for example, if there's fighting happening. It is not easy. So these are some of the difficulties. So when I talk about the MISP, this minimum standard, which we'll now go into a little bit more detail as to what are these exact challenges and what's really happening in the field. The 5 things that should happen at the beginning of a crisis in terms of reproductive health. One is that there needs to be coordination. Agencies need to come together and work together. They need to problem solve. They need to talk to each other. A priority is to prevent and then respond to sexual violence. So we don't have time to do all of gender-based violence, but the focus is on sexual violence, is on rape. Reducing HIV transmission, again, not all of sexually transmitted infections, but focusing on that life-saving priority. Then preventing maternal and newborn death and disability, and then starting to plan for comprehensive services. Of course, we want the communities to have access as soon as possible, so we need to start planning for that from the beginning. These are some recent assessments of the MISP. The most recent one was in Jordan in 2013, and I think the first one was in 2001 with Afghan refugees in Pakistan. So these key activities, the first thing that should happen is that there should be an agency. A crisis happens, international actors go in, they start setting up health services. Somebody needs to be responsible and accountable for the reproductive health response to ensure that services are being implemented. There needs to be an agency identified to coordinate the reproductive health response and move that forward. To have a focal point, to hold meetings, to report back to the other health actors, to work on supplies. That's what should happen. That's what the guidelines say. In reality, it is really rare that a reproductive health agency is appointed. There are a lot of different reasons for that, which I can go into later. People are unfamiliar with the reproductive health standards. We'll go into the field and people will do a condom awareness campaign. And we should not be raising awareness when people are dying in childbirth. Those are not the priorities. It's bigger campaigns. We need to make sure that these life-saving services are available. There's a lot of poor leadership and high staff turnover, which will absolutely undermine an effective response. Irregular or inaccessible meetings. So for example, in Haiti, the reproductive health meetings, the reproductive health response and I know that she's going to tell you much, much more about that in detail. It was quite mixed. So they did have meetings. The agencies, there was an agency appointed, a really fantastic reproductive health focal point, got on the ground within 1 week. But then they held their meetings on the UN log base. So the UN had this base right out sort of on the edge of Port-au-Prince. But they did not allow Haitians to enter this log base. So all the Haitian groups, all the women's organizations who were on the front lines, who were providing services, they could not access that reproductive health coordination meeting. That's not okay. There are often huge delays in supplies. Again, with the Haiti example, we couldn't get supplies into Haiti directly, so they had to go through Santo Domingo and overland. So the supplies flew into Santo Domingo and then were transported over trucks. And then at the border police demanded, I think it was $10,000 per truck. They're like, we don't have $10,000 to bribe the border guards to get these supplies over. But those are some of the realities on the ground. This is a coordination meeting in Haiti. It's a health coordination meeting. There were up to 400 people in some of these meetings. It was a giant mess, to say the least. There were a lot of challenges. And one of the things, the barriers that we see in reproductive health is that a lot of, especially health actors, will say, well, why do you want to split it off? Reproductive health is part of health. Which is absolutely true and should be integrated into primary health care. But what ends up happening at meetings like this is that people are so focused on infectious disease and trauma, reproductive health always slips off the agenda. There's just not enough time in a lot of these health meetings. And there are special needs. And a positive example, this is among Burmese, or Myanmarese as they prefer to be called, refugees in Thailand. It was a group, there were various groups working on adolescent reproductive health. And granted, this was not during the acute phase. As I'm sure you know, the refugees have been there for many, many years. But they were amazing. They met together every Thursday, they collaborated, they coordinated, they were separate from the health actors but still reported back. They were able to make real progress on on getting services available and working with the community to access them. Okay, in terms of sexual violence, that's the second priority, the second activity that should be implemented in an emergency. Prevention and response. So prevention in terms of preventing sexual violence, and then responding in terms of the clinical care. So making sure that women and men and children who have suffered sexual violence can get the medical care that they need. And then also to ensure that the community is aware that those services are available. The reality on the ground, prevention is not prioritized generally. And I think one of the problems with this is that it's a cross-cutting sector. So every sector needs to think about and integrate protection specifically towards sexual violence into their programming. So for example, with camp management, if you're an agency that's setting up a camp and you're not separating latrines, for example, if men and women have to share the same latrines, you are putting them at risk for sexual violence. With food, if you're providing food and you give women, 50-kilo bags that they're not able to carry, especially if they're carrying a child, again, you're putting them at risk for violence. So prevention cuts across all sectors, and it's just not mainstreamed enough. Psychosocial care may be prioritized, or at least, I don't know if it's prioritized, but it's often, when we talk about provision of care for a rape survivor, the orientation tends to be towards psychosocial care rather than medical or clinical care. There aren't that many people who are trained to provide adequate care for rape survivors in the US or really anywhere in the world, but also in humanitarian settings. Cultural stigma prevent women from coming forward, again, like in this country, and much more so in other more conservative settings. The community isn't aware of where and why to come forward. So there was an assessment done, it was in Burkina Faso, and it was last year. and it was with the refugees from Mali coming over. And they had, shockingly, amazing services available. So there was an assessment, and MSF, the Doctors Without Borders, are actually quite good at providing, regularly providing care for rape survivors. So the health facilities assessed, yes, we have, emergency contraception, we have someone who will refer to psychosocial care, we have all these different elements in place. And then when we talked to the refugees themselves, everybody was like, what? Where? We don't know where to go. We don't even know why to come forward. And I think part of the issue is people don't even know that emergency contraception exists. They don't know that there's a medicine that exists that minimizes HIV transmission. So it's not enough to say, okay, health services are available, but you need to inform people as to why they should come forward. You need to make it confidential. You need to make it safe. These are some of the challenges around sexual violence. These are Somali refugees in Kenya. A long-standing issue is that traditionally, although this is changing, is that fuel was not regularly provided in humanitarian settings to refugees in order to cook their food. So they were given food, plumpy nut, among other things, but they're not given a way to cook it. So refugee women, or displaced women and girls, often would go out to collect firewood. And doing so, they would put themselves at risk of rape. Also, even if fuel is available to cook food, because there isn't income generation, people don't have ways to make money, they will still put themselves out at risk because they want to make some money, and selling firewood is an income generation activity. Again, here you see a woman carrying giant food bags, which is difficult. I like to show the sort of negative examples and then the positive examples. So this is after the post-election violence in Kenya in April 2008. I can't remember who set these up. Sorry, maybe Save the Children, but I'm not sure. But these are latrines. You can see they're separated. They lock from the inside. These are according to standard, and this helps reduce the vulnerabilities to sexual violence. In Guatemala, these are refugees who, again, MSF, who generally does this pretty well, receiving information where they can go to receive care after rape, why they should come forward. Okay, in terms of the third activity, HIV, we want to ensure that standard precautions are in place, hand washing, making sure that you get rid of your sharps properly. You want to have condoms freely available, not distributed because that can be offensive, but make them discreetly available. And you want to make sure that blood transfusion is safe. In terms of what happens, as I mentioned before, condoms might be perceived as offensive. People will undertake condom campaigns, a month-long condom campaign when it's an acute emergency and we need to prioritize other activities. Health workers may take shortcuts. They might, in terms of hand washing or other basic protocols. Blood for transfusion may not be screened or performed under inappropriate conditions. So I think this is from Mindanao. It's from my colleague from UNHCR. I think it's in Mindanao, southern Philippines. I can't quite remember. So this was a waste disposal site outside of a clinic, and it wasn't sealed or covered properly. So you can see the really flimsy fence, and you can see that people opened it up. And one of the risks here is that, especially in very desperate situations, people will scavenge. They'll scavenge for supplies, wash them out, and then resell them to pharmacies. And that's what was happening in this setting, which is obviously extremely dangerous. We have a 2-year-old boy receiving a blood transfusion here. We have a condom dispenser right here on the side of the clinic, so people can come and discreetly receive condoms. Young people can as well. And then there's a sharp box, a safety box. The fourth activity is emergency obstetric care. So obviously we want to make sure that pregnant women have access to care in crises. That there's a 24/7 referral system available. Women give birth, at any time of day or night. They need to have access to care at all times. Women who are visibly pregnant need clean delivery kits. Yes, we would love if everybody gave birth in a health facility, but the reality is in many settings they won't for lots of different reasons, including lack of access in terms of transport, etc. So they need to have a clean delivery kit. And again, community needs to be aware of services. Some of the challenges in the field are health facilities are destroyed. For example, in South Darfur, there was this really great emergency obstetric care system set up, or that's what it seemed like at the beginning. So there was a clinic in one of the camps, and they were referring to in Kalma camp, and they were referring to the referral hospital in the capital of South Darfur. They had, a way to bring women to that clinic. They had a referral system 24/7. It looked really lovely. So we decided to follow up at the referral hospital. Okay, what's happening to these women? The referral hospital had no running water. They were basically sending these women there to die. They did not have access to care. So part of it needs to be a holistic thought process. You need to follow up. You need to make sure that women are receiving care and access along every step of the way. Lack of transport. A lot of times you'll have, even if you have a driver, even if you have a vehicle, maybe you might not have a driver, you might have run out of gas that day. In Kenya, we had a driver, it wasn't Kenya, it was somewhere else. There was a driver, we had gas, driver, and a vehicle. But we had no communication with, we didn't have a cell phone to reach the driver. So the driver was out like frolicking, smoking a cigarette somewhere. A woman had an obstetric emergency. We could get in touch with him. She wasn't able to reach the hospital. So lack of communication system. And again, the community is not aware of services. I've seen in many places excellent referral systems, not many places, some places, excellent referral systems, and again, women don't know they're available, they don't know why to come forward, and they continue to give birth outside of a health facility. These are Hmong refugees in Thailand receiving care. This is a Somali woman, she's 9 months pregnant, I don't think you can tell, but that's her clean delivery kit. You can see the contents of a clean delivery kit, and she safely gave birth 1 week later. This was in Kenya, the Ministry of Health and International Medical Corps, IMC, they collaborated together and made this vehicle available 24/7. They had money for a driver, money for gas, money for a cell phone. That was and also a really lovely government NGO collaboration. Okay, the last one is about starting to plan for comprehensive care. You want to start collecting data on reproductive health. You want to identify sites where can we start rebuilding in a more substantial way? Where can we make sure that comprehensive reproductive health services are available? You want to start identifying the training needs. Maybe you don't have enough staff who can provide care for rape survivors, for example. You want to start identifying those training needs to start training the staff once the acute phase is over. And then identifying procurement channels. Again, major procurement issues. I have many stories about procurement, really difficult to get the supplies into the field, difficulty in collecting data. Sites for reproductive health services and health facilities are destroyed. It's difficult to get them up and running, and this is one of the least addressed components. This is an inflatable tent hospital that MSF can put up. I think, and somebody could correct me if I'm wrong, I think you can put it up completely, it's a hospital, in 48 hours if you have 3 shifts of 4 people working around the clock. It has 9 beds, I can't remember all the details, but it is a completely functional, self-contained hospital. I think MSF might be the only agency that is able to do that. So this is fantastic, also in Haiti. It's my old boss. The head of the Women's Refugee Commission's Reproductive Health Program. And this was our colleague, Jonathan from UNFPA. And these are all these reproductive health kits. So they finally, this is Darfur, they cleared customs in Khartoum. They finally, all these kits with all these supplies finally got to Darfur. And then they didn't have a truck to transport them to the clinics. Those kids had sat there for 4 months by the time we came. Now I'm getting riled up again. They were there for 4 months and they had not gone out to the fields. Some of the realities on the ground. The MISP has changed in the last few years because it is very basic. And one of the things that we do see on the ground is that women want other services as well. They want contraceptives. So the MISP is currently being modified to add some of these key components. Contraceptives, people who are on ARVs, on antiretroviral treatment, they need to continue their care. People who present with sexually transmitted infections also need to receive care, and then menstrual hygiene kits as well. Some other important issues to consider, young people and adolescents, really important, very neglected, absolutely need reproductive health services in these settings. Refugee camps, the idea of sort of 1980s idea of a refugee camp is really becoming outdated. I think 1/3 of refugees now reside in camps. It's really urban settings, so peri-urban settings. We need to engage with men and boys. Reproductive health is often associated with women because they do have more reproductive health needs, but absolutely we need, and not just, a lot of the language around engaging men and boys is to engage men and boys in order to enable women to have services. Yes, that's important, but men and boys need services too. It's not just a means to an end to get care to women. These are some really cool boys in Azerbaijan. I like them. And then you see a father and his child, urban IDPs in Colombia. And if you want more information, I suggest going to the IWOG website. Anybody can sign up for their listserv. We have a bunch of resources, and also the rhrc.org website has some good information as well. Thank you very much.
Well, greetings, everyone. I'm glad to see a few men in the audience. They really need the support of our male colleagues in the area of reproductive health. I decided that I would try to speak to you from experience more than from the academic point of view, and I'm so grateful that the overall data on the importance and the numbers that are involved has been presented. My experience has been mostly in developing countries. I don't have any pictures left from the Congo, where we were during independence and where we took care of many victims of rape and sexual violence in 1959, 60, 61, during the early stages of what happened in the Congo. But I can talk to you about my more recent experience in Haiti and the lessons learned, and I wanted to share with you some of the lessons that we learned there, trying to help the Haitian people, and especially Haitian women. So the primary issues I hope to get over today, but they'll mostly be from anecdotal evidence, but I'm going to try to touch on all these things. And one are the immediate consequences of violence. I think that's been pretty well covered. Access to services, continuity of care, supply chain problems, the consequences of increased mobility, and the importance of monitoring and evaluation in the face of those. Then resource assessment versus needs assessment. I tell my students in public health often that if they want to do needs assessments, get a roll of toilet paper and start writing, and I'll go all the way from here to Union Station. You'll still be writing on about the needs. How about looking at the resources? That's where the answers really are. And this is particularly true in reproductive health. I'm going to talk about a little bit more about that. And then overcoming cultural barriers. There are some specific ones that showed up in Haiti that we hadn't expected, but in any disaster setting, you will find the cultural influences become overwhelming sometimes. And then the use of community clubs, groups, and participatory adult education. Let me just pause there before I go to the next picture. And I apologize if people have heard me speak before, but from the Coca-Cola industry research, I'm going to ask you how often do you have to see a new kind of Coke advertised, either hear about it or see it, before you try that new kind of Coke? Anybody have a guess? 7 times. You have to hear the message 7 times before you're willing to try it, okay? And now, before you regularly use that as a habit, how many times, this comes from the golf industry, it turns out, if you're swinging your golf club the wrong way, and someone's trying to get you to correct that, how many times do you have to do it correctly before it becomes a habit?
21.
21 times. That's exactly right. So I want you to keep that in mind, because we're talking about awareness and educating, letting people know, and we think we've given the message, okay, out of here, we gave the message once. That's not adult participatory education. And I think of the women who so often have said to me, why did they keep showing that picture of a bull with horns and talking about something they call the IUD? That's of course, the uterus and fallopian tubes. And all over the world, people say to me, why did they show us the bull with horns? So our participatory education has to be much more hands-on and much more close to where people really are and where they really live. And then, once that's done properly, how many times do we allow that to happen? In Haiti, we were educating about HIV and how to prevent it. Luckily, I turned it over to our Haitian health educators, who were wonderful. And they did role plays. And one of the girls would play the role of a woman